Hi all, good afternoon to all distinguished guests, ladies and gentlemen. Today we are very blessed to have Dr. Claudio Gali, an expert on the evaluation for diagnostic and prognostic markers on infectious diseases, our industrial talk. I am Dr. Sharifah Sakina, who will be the moderator for the session. Before I proceed further, please allow me to first introduce our speaker today. Dr. Claudia Gali from Abbott Laboratories is a Global Associate Medical Director for Infectious Diseases. He graduated in medicine and specialized in gastrointestinal disease in 1984. In 1988, Dr. Claudio received his PhD in infectious disease, and later he managed a research project with the National Institute of Health in Rome, Italy. He was then appointed as Professor of Contract in the field of microbiology and clinical pathology at University of Roma, La Sapienza. He has also authored and co-authored more than 160 papers. He is also a reviewer for many journals such as Clinical Microbiology and Infection, Blood Transfusion, and BMC Gastroenterology. He has participated as a speaker in more than 150 congresses, webinars, and CNE courses. His talk today will mainly focus on the SARS-CoV antibody testing, on why, who, and when. Therefore, without further ado, let us welcome Dr. Claudia Gali. Over to you, Doctor.
Thank you very much, Dr. Sharifa, for the nice introduction. And I'm very pleased to be here with you this afternoon. I hope my throat will stay fine. I've experienced some trouble, so will pardon me if I have some blunts here and there. And I'm very pleased to discuss with you the topic I've been asked to. And I have to say that this is, I would say, quite timely, because the more we go on, the more we will need to understand which are the actual hurdles to face and how serology, among the other weapons we have against COVID-19, may help us in dealing with issues. First of all, a very short recap on what's happening over the course of the infection. As we all know, there is an infectious phase even before the start of symptoms, if symptoms do ever develop. And in that phase, the only way to ascertain the infection is to test directly for viral components. And this is also happening over the first couple of weeks after the onset of symptoms. Then, from then on, we are in a gray area, if you wish, in which very frequently the RNA and especially the antigen assay will not yield a positive result, and at the same time, antibodies towards SARS-CoV-2 start to develop. In this infection, as you know, the lag between the IgG and IgM positivity is not huge. Actually, in many instances, IgM appear to be detectable first. But the relevant thing is that while IgM drop off pretty quickly, IgG stay on very long after that, and we will see how long in a few minutes. So we have a definite chance to help diagnosing the infection after the first 2-3 weeks after the onset, relying also on serology. Now, the point could be which kind of serology, what are we aiming to? And just to give you an idea on the first topic we are discussing, which is the likelihood of having a positive result after the infection, you may see at this very recent paper coming from your area, by the way, in which 3 different assays that are targeting the spike or the RBD portion of the virus are yielding a positive result in most of cases after 2 weeks from the onset. So this is a definite help. And this will try and cover nicely the very first phases, what is called the late acute, if you wish, in this kind of infection. But this is just the first glimpse. And as you know, almost all assays were initially validated and authorized on the purpose of helping diagnosis. But what happens then? What happens after this first phase? And we must, first of all, try and get a look on what is the likelihood of having a true positive by any kind of assay we are using. These are data from an external study on the Abbott IgG2 assay. And as you see on the right, the negative sample distribution is very good in the sense that very few samples actually are close or nearly close to the assay threshold. So this will guarantee a good specificity that, of course, will also rely and transfer to a very high positive predictive value. Although, of course, you may expect false positive, especially if you're dealing with a very low prevalence setting, which unfortunately is not very frequent nowadays in no country in the world. But again, what would we expect when we go on further during the infection? First of all, there is a huge difference, I'm sorry, There's a huge difference between the decay of antibodies targeting the nucleocapsid portion of the virus and the decay of antibodies that are targeting the spike portion. You see here this example on the left. You see that after 1 year from the infection, just barely 15-20% of samples are still positive for nucleocapsid antibodies, whereas antibodies targeting the spike RBD are positive in most of cases. If you wish to detail more, we do have also estimates on the half-life of the respective specificities. As you see here, by two different methods, it has been established that the mean half-life on antinucleocapsid is more or less 2.5 months, whereas for anti-RBD, this stays on for more than 7 months. Then, if you wish to look at this another way around, the likelihood of having a negative result in 50% of samples taken after a positive PCR result, well, this likelihood is reached after more or less 7 months for the nucleocapsid, and it has been estimated to be more than 2 years for an RBD, which means that 2 years from the first detection of the virus, half of the population will still be positive for anti-RBD. In a natural infection, then of course we must take into account also the likelihood of many people getting vaccinated, and this is, as we will see, a different story. And if you wish, this is the snapshot out of the study I've outlined before. 97% of patients were positive at the first month of observation. Some of them early detection were missed, and 96% still positive after 1 year. So we are pretty safe in using this kind of assay, even on the long run, after a lot of time has elapsed from the infection. The predictors for antibody decay are the MACE-X, RH plus, and of course, the estimate relies also on which titers will be seen soon after the infection, 3 to 6 months after the infection. So we are hinting that we should be looking also at the levels of antibodies, not just at the positivity or negativity for such a biomarker. Now, what happens if you try and apply serology in the context of a wide population? We have a couple of examples here. This comes from East Europe. We should focus on the middle part of the slide. Of course, if you are dealing with people that are aged 80 years or higher, these people are mostly symptomatic, unfortunately, so the ratio between antibody positive and PCR positive is almost 1. On the other side, in very small children, which are mostly asymptomatic, the ratio is absolutely highest, 16 to 1 antibodies to PCR. But in the middle ages, if you wish, adolescents and up to not so young adults, the ratio is about 3 to 5, which means that there is one case that is diagnosed by PCR every 4 cases that will be diagnosed as infected by serology. And this has been also outlined in a study from the US. You see that in that area, the estimated rate of COVID-19 cases based on official records was around 9%, but when serology has been run, it raised up to 35%. So definitely, if we want to survey any given population for the spread of the infection, the best way to do that is by serology. And this has been confirmed also by other recent studies I could not insert into the presentation for today, but we may look at those. And of course, this couples very well with the need of ascertaining how many people out of a given population have actually been infected over time. These data are coming from Russia, St. Petersburg area. You see the steep increase in antibody positivity when you test, samples have been tested in the late spring of last year and then in the first period of this year. So by the estimate of these authors in that area, 44% of people were naturally infected by April 2021. And if you add up the percentage of people, population that has been vaccinated, unfortunately not huge in that area, barely above 11%, then you have more than 50% of the population that we may define as immune to the infection, which is a step forward to herd immunity. Still far away, because you know that we should reach at least 80% and possibly more due to the emergence of the new variants. But this, of course, needs to be considered if you wish to have any idea on how also to prioritize and stress vaccination. Another very nice example is coming from the Lone Star state of Texas. You see here a different estimate based on the rate of people that have been fully vaccinated, that of course is increasing over time, then the antibodies from a natural infection, and then the sum of the two. So definitely, even in this case, if you compare the positivity rate to the diagnosed cases, which is a slide I have to hide due to time constraints, you will see that there is a huge difference, about 5 to 1. But now we have to also to consider what we started to tell a little bit earlier. That is, we may detect antibodies toward the nucleocapsid and towards the spike. And all of those antibodies do bear a significance. On a snapshot you see here, I'm talking, of course, about the Abbott assays. We do have the likelihood or the possibility to detect nucleocapsid. IgM towards the spike, as we have seen before, decay much earlier. So after 3-4 months, barely any individual is already still positive. And then the antibodies towards the RBD, which happen to be detected in a quantitative fashion. So if you wish, I proposed one of the workflows that may be used is to detect anti-spike first, and then in case of a positive result, go to nucleocapsid. If you do see that both antibodies are positive, this is very likely a resolved natural infection. If by chance the antinucleocapsid is negative, then you have two chances. Either the person has been vaccinated when testing blind, you don't know that at first instance, or a prior infection has occurred many months before. How many months? 3, 6, 7, it depends. The more we go on, the more likely it will be that we'll have this kind of picture, of course. And this has been used, by the way. Another experience I read briefly here, the authors tested for both specificities, and of course, over time, and especially over age, they were able to find quite a difference in the sense that the younger age classes have not been vaccinated so much. So the rate of positivity of antibodies of any origin or from a natural infection is almost the same. If you go to the far right, people aged 50 years or more, then in that case, the self-reported vaccination happened in the majority of cases, and so as a consequence, only a minority of patients had antibodies due to a natural infection. So once again, you may combine the different results in order to shape the epidemiological picture in any given area according to what is the need. And thinking about infection and, of course, protection, because as of now, we have just dealt with antibody positivity. Does it equal protection? There are many doubts about that, and there are many works that are still to be done, but I may present some data that I hope would be of interest. First of all, this comes from Israel. You know, Israel has been the country that was fastest to reach a high rate of vaccination coverage. But at the same time, when they looked at a huge database of about 5 million individuals in that country, which is the majority of inhabitants, by the way, they found out that the protective effect of vaccination and natural infection towards 3 parameters here that are hospitalization, severe disease, and infection as a whole was about the same. If you wish, it was slightly higher after a natural infection. Again, I'm sorry I did not have time to insert that, but there is another very recent paper from the same country that actually hints that the natural infection antibodies towards COVID-2 after a natural infection stay on longer and may guarantee also a higher protection compared to vaccine antibodies. Of course, with all the caveats, we are dealing with a single country, a single vaccine, which is the BioNTech, and of course, there are many confounders there, but just to give you an idea. And we do know that the ultimate solution we have everywhere to curb this infection and this disease is vaccination. And vaccination has been started everywhere with different vaccines, different rates of coverage, different effectiveness, but definitely is the way we should proceed on to. And one thing that was explored very nicely by a couple of modeling studies is that indeed there could be an advantage in prioritizing vaccination based on the prior antibody status. Just a couple of data here. First one compares what will happen if you have 500,000 doses of vaccine and you're vaccinated everybody or just people that are negative for antibodies, that is, no prior infection. in a snapshot, what happens is that you will need 6 doses of vaccine to prevent one single infection case if prioritized by prior immunity versus 12 if you do give the vaccine to everybody. Of course, many variables involved. Another way to look at it is what happens if I have to look at an 80% coverage by vaccination on everybody or just on people that were negative for antibodies. And again, you have the same ratio. You need almost 9 doses of vaccine to prevent one case versus 20. And this is something that did not happen and never happened so far. But I think there is still time to consider that, also because the effect of seropositivity on the impacts of vaccination has been demonstrated to be quite huge. You see here 3 different outcomes, that is infections, deaths, and years of life lost. That the different colors are related to different age groups, and the solid lines represent the effectiveness if the vaccine is administered to everybody, and the dashed line are the administration of vaccine only to antibody negative. The assumptions here for antibody sensitivity and specificity are pretty logical because this is exactly what we have seen before. The point here that is, I would say, an error is that it takes in account a 3-month seroreversion, whereas the seroreversion, as we have seen, happens to be to be verified much later. But anyway, the effect is clear in all age classes. This is something that happens before. Then we have to look at what happens after. And as we have said, the solutions that are brought up nowadays are for quantitative antibodies. And here we do have troubles. We do have a reference preparation from the WHO. You see here, you know that already has been released in January this year. And we, by the way, we do have some different preparations also from the European Commission that are not so popular, I would say. But the point is that this preparation has an assigned unit age that is quite low. So it is not really feasible to recalibrate assays based on that standard, especially if assays such as the one we are dealing with today have a very wide dynamic range. But you may convert values. There is a formula, very simple. You take the arbitrary units by that assay and multiply by this factor, and you obtain the binding antibody units, which is the standard units, by this kind of preparation. If you wish, you can take the arbitrary units and divide by 7. You get exactly the same result. Maybe it's easier. Okay? What is the need of having a huge dynamic range that forces to make this kind of conversion? Well, actually, if you look at the antibody levels towards RBD that are raised in the different phases after infection or vaccination, you see that indeed we need to go up to the levels that are allowed by that assay. It is up to 80,000 arbitrary units per ml, especially if you're looking at patients that or people that are taking vaccine after the second dose, and in many instances also after a natural infection. So if you wish to obtain a clear-cut result right away without dilution, this is the only way to do that. And this will allow also to establish very clearly the difference in levels across people or in the same individual over time. And this happens quite often. As you see here, this is a comparison between the antibody levels raised, but this is a different assay, by the way, but the significance is very clear. If you vaccinate by the BioNTech vaccine we have already dealt with before, you do have a very high response very short after the second dose, and also the wane of antibodies leads to high levels even after 2 months or more. If you have the Oxford vaccine administered, the levels are much lower, which will not absolutely mean that the vaccine is not effective. It means just that it raises lower antibody levels. One thing that we did not discuss so far, and it's relevant, is that in all assays you will find available, you are actually detecting, there is a person that can't hear my voice. Is the audio okay?
I think I can hear it clearly.
Okay.
Yes, I'll proceed.
Okay. Thank you so much. Then, of course, we are detecting binding antibodies. The antibodies will bind to the RBD portion of the virus in this case, or the spike portion in other assays. What we may try and look at is a different solution, but this First of all, I would like to remind that in many instances, unfortunately, vaccination will not raise an antibody positivity. If you go to special groups such as lung transplant recipients here, you have a very slim chance to have a seroconversion after vaccine. And this prompted also some assays, some trials to use a third dose of vaccine. Now, I've mixed feelings about that. In my opinion, it will be needed in fragile populations. But before going on the third days on general population, we should be sure to give enough vaccine to all of the world. This is also the position by the WHO, by the way. But you see here that if you administer the third dose in solid organ transplant recipients, then you have a higher response and higher antibody levels, quite predictably. And okay, the same in kidney transplant, but I don't want to lose your time here. Another thing that we should consider is that when vaccine is administered to people that had a prior infection, there is a boosting effect. This is one of the several papers that have demonstrated that. You see here that in prior infected, after just the first dose, there is a booming response, and after the second dose, the levels do not change much. So actually, it appears there is no need to give a second dose to people with a prior infection. And the levels are also quite different, as you see, if you compare the naive individuals to the experienced individuals on samples taken 2 months after the vaccine administration. Again, same data here. So in a nutshell, what happens and what has been already recommended by several health authorities in different countries is that people that have prior infection do not benefit from a second dose of vaccine. And possibly there could be some harm there, at least a few papers that suggested that by immune exhaustion. But again, we are wasting vaccine doses if we are going to give the vaccine to people with a prior natural immunity. There's no way to help those policies. How to do that? One simple thing could be to take a sample to be tested for antibodies at the time of the first dose. So in case there is a prior antibody positivity, you may stop there. What about protection? This is difficult. There is a correlate between antibody responses, neutralizing and binding antibodies, and the vaccine efficacy. This has been ascertained by different vaccines in different studies. The point is that we do not routinely test for neutralizing antibodies because the procedure is quite cumbersome and it is not allowed and available in every lab. So we must rely on binding antibodies. So the question is, do they correlate to each other? Is there a way to establish a proxy to neutralizing activity based on the levels of binding antibodies? And indeed there is. You see here as an example, 2 different assays targeting the spike portion, the RBD portion in the tail, and you see that in both instances there's a very high and nice correlation between the levels of antibodies, this is log2 units, and the levels of neutralizing antibodies. This has been, by the way, the neutralizing antibody assay has been calibrated towards the WHO standard we've seen before, which is a multi-purpose standard that should allow to consider both neutralizing and binding activity, with all the differences, of course, related to different assays. If you note, this is especially true in this area, let alone here the plateau or the negative ones. It is especially high in the area of interest. And we, by the way, have other evidences here. In this instance, the authors did a very nice job because they did compare several assays for binding antibodies with neutralization, and NT50 means the level of neutralizing response that is able to inhibit virus growth by 50% till culture. And you see different numbers here. So this is the assay threshold. This, if you wish to ascertain a neutralizing response as an absolute sensitivity, but it's not so specific. If you raise to 500, you have a high specificity and a lower sensitivity. But the point is that we should not be interested in a general neutralizing response. We should be interested in a highly neutralizing response, because a general neutralizing response is detectable also in the first days after infection and is not protective at all. And this is why we did compare the levels of antibodies with the print assay here, in which the protective level or high neutralizing response is deemed to happen at this kind of dilution. If you wish, then, if you have this level of antibodies by the binding assay here, you have a 90% likelihood of having a strong neutralizing response. And of course, this goes on further. So the higher the level of binding antibodies, the higher the likelihood of having a strong neutralizing response. And I have to warn that we will never reach 100%. We will reach that statistically, but you will always have a confidence interval out of that, which is what happens in biology in every field. And this is what happens if you use the binding antibody levels. You see that in people either with no prior COVID or with prior COVID after the first shot, almost everybody does reach this protective level of neutralizing antibodies. The last thing I have to deal with very briefly is what happens when you're dealing with variants. This is a different chapter, and we may spend one whole day on that. But you see here the three most famous variants of concern. The evidences we have gathered so far actually tell us that if you look at antibody titers still by the Abbott quantitative assay, if you have a level that is 2-3 logs log 10, which is 100 binding antibody units, you may neutralize the British variant, the first one, but not the other ones. But when you have 3 logs or more of antibodies, which is 1,000 binding antibody units, then you have a good neutralizing effect on all variants considered here. And this is very clearly depicted in the graph, and not so clearly, unfortunately, because in the preprint, the graphs are not ideal, but you notice that there is this very nice correlation between binding and neutralizing in all 3 instances. That is, the first original strain with a single mutation that appeared in February last year, and then also in the UK and the South African variant. Of course, the neutralization level will decrease on the latter because you need that this variant actually escapes more the neutralizing capability compared to the original strain, but it's still there, and you still can rely on the binding antibody levels in order to have a proxy to viral neutralization. Okay, that's all. The conclusion here, and I hope I covered it decently, is that we may use serology on different purposes. That is, an aid of diagnosis in late presenters, and it's to establish the prevalence prior to vaccine, and this could be very useful if you need to forecast the vaccine need in any given population. Assessing prior natural immunity, because as we have seen, makes little sense, if any, to give a full vaccination course to priorly immune. Then, of course, to verify an immune response to RBD, assuming the vaccine you're using is targeting as the RBD spike portion, and establish correlated to neutralization of efficacy. And thus, I did not detail on that, unfortunately. If you happen to test vaccinated people that are negative for anti-nucleocapsid, and they happen to become positive, that's a vaccine failure in the sense that the patient got infected despite the vaccine. I think I was on time. Thank you so much for your attention, and very nice to be here with you today. Thank you.
All right, thank you very much, Claudio, for a very insightful talk. Okay, it was very informative indeed. Well, since you are limited of time, okay, I can just ask you one question. Okay, it is from the participant. How about the IgA, one of the secretory immunoglobulin? Okay, they can be found from nitrate infection induced. What is your opinion on its stability in human blood?
Well, IgA has become popular last year because one of the first assays available did detect also IgA response. Actually, for the sake of diagnosis, it has more or less the same value as the IgM, so for recent infection. As far as protection is considered, unfortunately, we are just looking for the time being at IgA, circulating IgA. It would be much more relevant to look at local IgA response. That is what happens in the upper air tract. And here we do have differences because some vaccines have been demonstrated to elicit that kind of response as well, which will guarantee a better protection towards infection. Some others do not. So if we come up with a decent way to look at secretory IgA, it could be a nice addition.
Okay, thank you again, Dr. Claudio. Well, to all participants, well, if you have further questions, I think Dr. Claudio will be very much happy to answer your question. Is that okay, Dr. Claudio? All right, thank you.
Absolutely.
Okay, so in interest of time, okay, we shall close the session. Okay, thank